A very warm good afternoon to all of you. So I'm going to be talking on macular buckle. So this is going to be another extraocular surgery. My mic is muted.
Suganeswari is not heard, is unheard of.
Huh? So warm good afternoon to all of you, and I thank the organizers for giving me this opportunity to be talking on macular buckle, which is going to be an extraocular surgery.
Please.
The mic, yeah.
Yeah.
Yes. So we are going to be talking on high myopia. So these are patients whose spherical equivalent is above -6 diopters, and the axial length is more than 26.5 millimeter. So what is myopic maculopathy? Here, first, I would like people to understand why we do these buckles, because these buckles are more easier than anything. But you must understand where to do and when to do it. So there are multiple classifications. One among them is the Etienne classification, where the first thing talks about the atropic myopic maculopathy. And in this, all the components are like you must have the excess axial length, which I had already alluded to, and the posterior staphyloma. And the next one is the tractional myopic maculopathy, where it starts from T0 to T5. So this is what we are going to be talking today, dwelling on this particular subject. So T0 means there is no macular schisis. T1 is you have inner and the outer schisis. I'm talking about the foveal schisis here. T2 means inner and the outer foveal schisis. And T3 is foveal detachment. T4 is a full thickness macular hole. T5 is a macular hole with a retinal detachment. So next is the neovascular myopic maculopathy, which I'm sure the others are going to be talking in the other session, so I'm not going to be talking on that. So now the other system which is there, which is quite now most the talk of the country or talk of the globe, I must say. So it is the myopic traction maculopathy staging system, which is called MSS. And in this, you should understand there's a retinal pattern, there's a foveal pattern, and there is an evolution. This is most important. So you label it as staging. The fovea, you talk about A, B, and C, and you also understand about the evolution. So you know the stage 1 to 2 takes 20 months nearly, 2 to 3, around 12 months, and 3 to 4 is 3 months. So if you add something like ROP when we say, plus and like that, here you have, if you use an O in front, then it is outer lamellar macular hole. If you use a plus, which means epiretinal membrane. So now here it is all about the game of forces. The forces means intravitreal forces, then the forces enacted by the sclera. So we must understand, go back to the Curtin's classification, where he described about the 10 types. So type 1 being the very commonest one. Now here is another classification which is given by our Japanese colleagues, which is most simpler to adapt. So this is from type 1 to the 6, 5 until 5. It's easy to memorize also. So type 1 is a wide macular area, type 2 is a narrow macular, type 3 is peripapillary, type 4 is nasal, type 5 is inferior, and the others. So now with this understanding, you should understand that when we are talking about these posterior staphylomas, you have a little lesser curvature from the sclera, which is an ectatic sclera, and which is also seen on the ultra wide field prototypes to understand where exactly the staphylomatous areas are. Because of these tractions is why the changes takes place. And you could use an ultrasound to classify it as mild, moderate, severe, very severe. Once we know these things, then we will know how to do it. So what are the ways in which you evaluate a staphyloma? By ultrasound, wide field fundus photography, the MRI is also being used, and the SSOCT as well. So now, this is in short the myopic traction maculopathy, the MTM, which is called, the first one is the schisis, the second one is the foveal detachment, the third one is the retinal detachment which you have. And also now the last panel, you must see the defect is all now in the inner surface. So if you have a lamellar macular hole, the full thickness macular hole, or the macular hole with retinal detachment. So these are the ones in which we should do the macular buckles. Now going by the pathogenesis, the pre-retinal factors, the subretinal factors, and the factors limiting the retinal elasticity. So the principles are in short, prevent an axial elongation, shorten the eye, flatten flatten the sclera, create a dome-shaped macula, and a non-drainage procedure. So here we have multiple evolution. The endosplum, which is the one which was used by the Japanese colleagues. So you identify, the most important thing is identify the four muscles which we all tag. The superior oblique, inferior oblique, you must hook it, and then the placement is along the lateral rectus so that it goes underneath the macula. So this is a scleral sponge, which is a 507 sponge, and this is L-shaped. You make it L-shaped by making the titanium stent, which is being used. So people have used multiple materials. Here somebody has done an orthodontic stainless steel wire. So these are all done to make these sponges easily into a flexible surface. So now our experience here is with a T-shaped buckle, the Morin-Devon's buckle band, and here the Morin goes under the macular plate. The Devon is a 2 millimeter solid silicone band which goes through the Morin. And here with our experience, what we have seen is the axial length reduction from 28.5 millimeter to 26.2. The visual improvement was seen in 40%. The complications are there with subretinal hemorrhage, hemorrhagic CD, the angle closure glaucoma. So you need to know when you will do what, the macular buckle, or would you do a pars plana vitrectomy, or you would do a combination with a peel, without a peel. How do you go about that? If you have a detachment, please understand it is a macular buckle. If you have a schisis, it is a macular buckle. If you have a defect in the inner sensory retina, you would do a combination of a macular buckle with a PPV if you are having the associated defect also. So then this is what it is to understand. The complications, as I've already alluded to, 78% is what I would like all of you to remember. It is the tilted disc syndrome. This is one thing which we should carefully see. If you have something like a tilted disc, then your macular buckle can be associated with a lot of complications. And now I pose in front of the audience one question. I will
Time
finish
is
it.
up. You need to wind up.
So in short, this is what it is: myopic traction maculopathy, where buckles are being placed, and where a macular buckle with a vitrectomy, and that's it. Thank you.
Thanks, Dr. Suganeswari. Dr. Suganeswari made it look very, very simple, but I'm not too sure if it's that simple. So I would like to ask the panelists, like, how many of you, I'm sure like most of us are not doing macular buckles. I have done a couple of them, but then I'm sure most of us are managing with vitrectomy. So what do you think is the clear indication that the macular buckle is required? Dr. Dinesh?
Yeah, so frankly speaking, I think I wouldn't do a macular buckle in most cases. I actually have found very good results with complete ILM peeling from the arcade to arcade, basically the entire area of the staphyloма. So if you take care of the vitreoschitic layer, the first thing is that you often have cortical remnants of a vitreoschitic layer. You know, sometimes it's a full layer, sometimes it's small parts of it. If you take care of that, then you take care of the entire ILM from the edge of the staphyloma all the way. Most of the time it settles. In fact, I was just seeing the results, not talking about, you haven't told us how many actually settled. Because if you have a detachment without a hole, you don't even need to put oil. It will settle, but it takes a few weeks to months.
Okay. Dr. Naresh, would you do a macular buckle?
I have never done that.
So,
And some of it is not that freely available also.
correct.
So
it's not available. The,
it's not freely
Morin
available. So
Devon
unless
buckle
otherwise
is not
it's available for everyone to use.
Correct.
In fact, I would like to know, I mean, I am concerned about its safety because the entire short posterior ciliary nerves, arteries are in that area, and you're blindly going into that area. So what is the risk of damage, and how would you assess whether you've damaged or not?
So it is like when you are passing the buckle, sir, it goes, you don't make tunnels all around. You just have to see that the tunnel, see there are many buckles you can decide. If you are using a Morin's one, then you need to go only through the superior oblique and the inferior oblique. There is no tunnel. It just goes underneath that, and you are lodging only the macular plate goes along your lateral rectus and then goes underneath. It's actually quite simple when we place it, because I placed it on retinoblastoma children, when I've had a break at the macula, so, and you have a tumor, you have a break also, so, and one single eye, then you have no other opportunity to do. So these are circumstances where unusual circumstances when we do. But here we are not talking about the routine myopia. These are very high myopic eyes where the axial length is more. And if you have already a failed vitrectomy, all of us do have that. When we no, there are cases in which
primary
very
eyes, like,
selected cases.
But like it has been like this, like as I mentioned, despite all these discussions go on between like all of us as well as Barbara Parolini and one of the Egyptians, I think it's still not clear, because I remember one patient who was actually posted for macular buckle by Dr. Pradeep in Shankar Nethralaya. The patient is from Bangalore. Then she went to the airport, she fell and broke her arm, and then she couldn't come to Chennai, and then she came here. So I did a vitrectomy, it settled. So that's how it is. It's like
yes.
It's not very clear. We will leave it at that. But then like I usually do a macular buckle if there's a recurrence or if there is a failure
Yes.
with the macular hole under full thickness retinal attachment, full thickness macular hole under retinal attachment.
Yes, agreed, sir.
Thank you.
Yes.
Thank you, Dr.
Thank you.
Suganeswari. Thank you
Sir,
so
you
much.
mean to say if the patient has got macular schisis with fracture of arm, they have got a better prognosis?
Correct. I agree. And if the patient has to go vitrectomy, if the patient falls